Good morning, everyone. My name is Danny Scott. I'm a professor emeritus from Cornell University, College of Veterinary Medicine, Ithaca, New York, and I'm coming to you live from Dubrovnik, Croatia. I'm very excited to be here, and I'm really excited that you're here too. We're going to have a look at the approach to differential diagnosis of the Pruritic cat. Are y'all ready? All right, here we go. There are many diseases that can occasionally or constantly cause pruritus in the cat, focal or widespread. But in feline dermatology practice, about a third of all of the patients we see have some form of allergic skin disease. And I'd like to take a couple minutes here just to review that. We see now displayed the classic allergic dermatitis of the cats. And the first three are by far the most common. I'll show you some data from our practice to put it in prevalence mode. But as we go down this list, we'll mention most of these conditions, except for contact allergy. That's an extraordinarily difficult diagnosis to make, and I'll be quite honest with you, I have not made that in my entire life in a cat. Intestinal parasite allergy used to be somewhat frequently seen when I entered veterinary dermatology back while the earth was still cooling, and we would treat the intestinal parasite demonstrated, and the allergic-like skin disease would disappear. When they would be reinfested, the allergic-like skin disease would reappear again. But now with, of course, the fantastic preventive schemes we have for controlling intestinal parasites, that is rarely seen today. This is some information that my colleague and I, Bill Miller, published some years ago. Experience with over 1,400 cats with skin disease in our clinic. And again, you can see at the bottom there, well over a third of the cats presented to our clinic had some form of allergic skin disease. I'll say a couple things about the first diagnosis, in quotations, allergy. Those were cats who were worked up to the point of saying they either had food allergy, or they had atopic dermatitis, or they had both. But the owners were not willing to go through a novel diet to rule out the food allergy possibility, so they remained either atopic dermatitis or food allergy, or both. Wherein we did make specific diagnosis, you can see in our temperate climate in the northeastern United States, atopic dermatitis was by far the most common form of allergy, dropping off quickly to flea bite allergy and food allergy. Mosquito bite allergy rarely seen, although we certainly have lots of mosquitoes. Using the allergic cat as the model, and then talking about the non-allergic things that can mimic allergic reactions in cat skin, these are the classic reaction patterns that we will see in the pruritic allergic cat. The first one we refer to as symmetrical, initially lesionless pruritus. And this is the type of cat who begins scratching symmetrically and has no lesions, apparently, in the beginning. But in the cat, this lesionless phase becomes quite dramatically lesional within 48 to 72 hours many times, because of the way, of course, cats are armed with claws in their hind paws. Typically, this pattern manifests itself around the face, the head, the pinnae, and the neck, or some combination thereof. The eosinophilic granuloma complex, we'll look at the classic lesions of that in a bit. So could either be the indolent ulcers most commonly seen on lips, could be the eosinophilic fiery red pruritic plaques most commonly seen on abdomen, or the actual granuloma itself, most commonly seen on caudal thighs and around the face. Self-induced lesionless hair loss. These are the cats who overgroom essentially and produce the spectacular types of self-induced hair loss. And typically the underlying skin is perfectly normal in appearance. You'll see a parenthesis there with some quotations, fur mowing. That's the Cornellism for this type of cat. It's like this cat had a lawnmower and was just mowing its own fur down and leaving the skin perfectly normal in appearance. Papulocrustus, again in parenthesis, miliary dermatitis, those cats who develop those tiny crusted papules, especially over the back of the neck, their head, and running down their dorsal midline. Those would be the four typical patterns. Very rarely do cats develop urticarial lesions as a manifestation of allergy or angioedema or exfoliative skin disease or the odd plasma cell photodermatitis. We want to make sure before we get more specific on these patterns that these patterns do not indicate a specific allergic disorder. In other words, any of these patterns or multiples thereof could be seen in a cat with any given allergy. The other part that's critical to remember is that these patterns, although classic for and most commonly seen with the allergic cat in our practice, they can be produced by many non-allergic diseases. And of course, before we start taking a cat and the owner down the yellow brick road of working up an allergy with novel diets and testing and so on and so forth, we want to make sure we rule out these non-allergic diseases, which we actually have the potential to cure before we go any further. Cats, being the extraordinarily intelligent species that they are, they can actually do multiple combinations of these diseases in the same individual. In fact, in the study that I referred to that Bill Miller and I did, over 30% of the cats had at least two of these reaction patterns, and in many instances they had more. And I guess that's one of the things that always pushed me towards being a feline dermatologist is compared to dogs, cats are just so intelligent. I mean, dogs are just stupid, let's face it. If you're talking about an allergic dog, they have pruritus, they have it symmetrically, and they have no lesions in the beginning, and they can never, ever alter that. Cats are much more creative, much more thoughtful, and therefore much more difficult to pursue. God love them. Well, let's take a look at some of these classic reaction patterns that are produced in the allergic cat. And then we'll also talk about some of the non-allergic things that we must rule out in these individuals. The first one, which is the most common reaction pattern that we see in our practice, again, is the symmetrically initially lesionous, but only for 2 or 3 days, a pruritic cat. This is a cat who has atopic dermatitis. And typical history from this owner was that this 5-year-old cat was perfectly normal in terms of skin disease for the first 5 years of its life, and then suddenly and acutely started scratching at the face and the pinnae. And according to the owner in the beginning, there were no visible lesions. The owner would part the hair and see nothing. But of course, in a very few days, unless the cat were declawed, lesions start to appear, and they are lesions produced by the cat, excoriations. And those excoriations can then proceed to infection fairly rapidly. So here we see some of the excoriations that have been produced by this cat reacting to its allergy. This is the same cat who is producing mostly broken hairs, hypotrichosis, from scratching bilaterally at the pinnae. About 10% or so of allergic cats, be they atopic cats, be they food allergic cats, can present with predominantly or exclusively pruritic otitis externa. Some of these cats will have no otic discharge whatsoever unless they get secondarily infected. Some of them will have a profound ceruminous discharge to the point of being black and coffee groundish. And because of this black and coffee groundish appearance, they tend to get repeatedly treated for ear mites, otodectic mange, for prolonged periods of time until we see them on consultation, or they develop a drug reaction to the topical otic product that's being repetitively used. So 10% could present for just pruritic otitis externa. This is a cat who is allergic to milk and had a similar type of history. I believe it was 9 years of age when the pruritus suddenly and acutely began. If we were to turn this cat around and look at the other side of the face, there would be a similar type of lesion on the other side of the face. So again, symmetrical, pruritic, lesionless in the beginning, but not for too long. And you can see this cat has really dug into herself and created a severe ulceration, secondary bacterial infection of a deep nature at this point. This is a cat who also is food allergic, who began scratching predominantly at the neck. This cat really had no facial lesions and no penile disease, but really started working at the neck and created just this horrible excoriated, secondarily infected lesion that actually did a 360-degree all the way around the neck. This cat was proven to be allergic to fish. Here's a cat who had a similar history to what we've described so far for atopic and food allergic cats. The difference was this cat had been repetitively treated for recurring upper respiratory disease, and the cat was on its third administration of amoxicillin clavulanic acid and developed acute allergic type pruritus. And the message here is, we'll see over and over again, is when you're presented with a cat with acute pruritus, one of your first questions has to be, are you taking drugs? And if you are taking drugs, although drugs are the least common explanation for the cat presented to you, it's the allergy you can cure. You stop the drug, you maybe ameliorate the inflammatory disease for 2 or 3 days with corticosteroid, and then see if the condition comes back. Normally, we don't provoke the cat with another round of the same suspect medicine because, of course, there are some ethical and humane reasons not to do that. Unlike allergic dogs, allergic cats much less commonly lick and chew their paws. This is an atopic cat that, in addition to its facial pruritus and penile pruritus, was chewing at and licking excessively at all 4 paws. And you can see the traumatic hypotrichosis and mild erythema that this cat has produced. Whereas 80% or so of allergic dogs will attack their paws, only about 10% of allergic cats in our practice will significantly go after their paws. So those are some of the allergic things we would worry about. And again, in our practice, they're the most common things. But before we jump to allergy, we want to make sure we don't have something that we can cure. Dermatologists don't get to cure very many things. And so we get really excited if we think there's a potential that we can treat a mite, treat an insect, and actually cure something over a short period of time. So one of the things that will impersonate these symmetrically, initially lesionless pruritic cats about the face and the pinnae and the neck is early notohedric mange. Although the site of pruritus is identical, I think the thing for me that really pushes me towards notohedric mange early on are the lesions that tend to start at or be most obvious along the margins of the pinnae. There aren't many things in veterinary dermatology that affect the margins of the pinnae. And certain ectoparasites are right up there in the thought process. Vascular diseases can do that. Most allergies do not focus on the margins of the pinna, they focus on the pinna in general. So this is a great candidate early on for notohedric mange or perhaps sarcoptic mange. And so we want to make sure that either through skin scrapings right along that diseased margin of the pinna, or through treating the animal for suspect notohedric mange, we'd want to make sure that we had ruled that out first. We never want to miss the chance of curing a pruritic cat. And this was a skin scraping from the cat you saw. Notohedric mange, historically, the mites are easy to find, it's written, and that's certainly been my experience in the small number of cases I've seen over the year. If it is notohedric mange and you do adequate skin scrapings over a large area, you virtually always find the parasite. If you don't, and the thought crossed your mind that this could be notohedric mange, then I think you have to take a time out and you have to administer some kind of acaricide, parasiticide, as if this was notohedric mange, and reevaluate this cat in another 4 to 6 weeks. Similarly, here's a cat with early symmetrical, more or less non-lesional pinnal and facial pruritus. This has been going on longer than the cat with notohedric mange that you saw. But again, we have this focus of either hypotrichosis, scale to crusting, depending on what stage of the disease you're seeing, that's targeting the pinnal margins, very much like notohedric mange. This particular cat had sarcoptic mange, which in our practice occurs about as frequently as notohedric mange, which means very rarely. And I think with the increasing use, constant use of very good topical spot-on acaricides, the likelihood of us seeing this disease in many parts of the world becomes lesser and lesser. This is an image that was given to me many years ago by one of the early workers in veterinary dermatology, one George Wilkinson, then from Australia, later into the UK. God bless him. I take this slide with me everywhere I go in memory of George and what he did for me and what he did for veterinary dermatology. But another one of the acarids that can produce facial and pinnal pruritus in cats are the trombiculids, the so-called chiggers. And you can see these little orange macroscopic parasites here in the medial canthal area of this cat. You could also see them in the pinna, sometimes in between the digits. There are instances where a cat is coming in for disease produced by trombiculids, wherein you don't see the trombiculids because they tend to spend 7 days, 10 days or so on the cat and then drop off and leave an ongoing pruritic inflammatory disease behind them. So the diagnosis can be presumptive in many of these instances. Time of year is helpful. We see most cases in the fall and early winter. We see them in outdoor cats who can traverse the fields and such where the larval mites hang out. And then we can go ahead and treat on suspicion. Here's one of the little trombiculids harvested from the cat we just saw. Make sure that when you grab them, you hold on tight until you put them in mineral oil, because they can jump amazing distances, or put them on sticky tape, but they will jump away from you. I guess they're kind of like the cat. They're intelligent. They don't want to be noticed, and they certainly don't want to be caught and categorized. Another ectoparasite that will produce intense symmetrical pruritus about the face and the pinnae, not always, but in some presumably cats who are hypersensitive to mite protein of some kind, be it fecal, be it digestive, they'll present for intense pruritus and varying degrees of erythema, as we see in this kitty. This is bilateral. If we could see the other ear, we'd see a similar picture. And the cat has started to excoriate the temporal area, getting after the ears as well. What I think is interesting in these cats is these cats who apparently are hypersensitive to mites, oftentimes finding the mites is very difficult in my experience. The actual numbers of mites seems to be quite small, and an otoscopic exam can be negative. Sampling the discharge and looking for mites and eggs and such can also be difficult. So if there is any way that this cat presenting for an allergic type pruritus could have ear mites, and you would investigate that, of course, based on whatever preventive they were on. Do they have contacts with other cats? Did they spend the weekend in the animal shelter? Things of this nature. If there's any doubt in your mind, then again, I would take a time out and let's treat this animal for suspect otodectic mange and see what the animal is like in 4 to 6 weeks. You don't want to miss the opportunity to cure a disease. And this is a sample not from that cat, but from another cat, just sampling the otic discharge, of course, and picking up on the classic Otodectes sonotus adults and ova down here. Okay, so in summary, when we see that cat who presents with that classic symmetrical pruritic disease focused around the head, neck, and pinnae, this is our drop-down list, if you will, and sort of going from the most common to the least common in our practice. Again, yeah, the odds are that this cat has atopic dermatitis or food allergy, but is it on a drug? Is there some way that it could have an early manifestation of one of these parasitic and curable diseases? And we now know how to approach that either through sampling or through treating it and seeing what the response might be. The second most common pattern in the allergic cat is so-called self-induced lesionless hair loss, fur mowing. We talked a little bit about the Cornellism there. And those cats typically present this way. This is an atopic cat who actually has had clinical disease now for about 2 years. Back in the golden days of veterinary dermatology, meaning the Jurassic period, before we understood how smart cats were compared to dogs, the assumption was these cats with symmetrical hair loss had some kind of metabolic disease or endocrine disease and that the hair was falling out. This is particularly true because many of these cats, as you may know, are quite reclusive over-groomers. They don't like to have people watching them over-groom. So they will lick in the next room. They will lick under the bed. They will lick in the closet. They will lick while you're at work, but they would never allow you the joy of seeing them lick and produce their own disease. And this is a concept we have to get through to many owners who legitimately don't see signs of the cat producing this and often get quite offended when you suggest that the cat's producing its own hair loss. But of course, you look at the length of hairs and see how irregularly in length they are. That's not typical of endocrine disease or metabolic disease when hairs are falling out. They should be all the same length. You can put these hairs under a microscope and see that they're broken off at irregular angles. And of course, that doesn't happen with endocrine disease either. This is the same cat. The other thing that would mitigate against endocrine disease is look at how exquisitely well demarcated the hair loss is. Endocrine disease doesn't have that kind of imagination. We slowly lose hair. The coat looks a little rough. The coat gets a little thin. And then finally, years and years down the line, we have the symmetrical areas of hair loss that people put in their textbooks. But this occurred at the very beginning, these well-demarcated lesions, and that's just totally inconsistent with endocrine or metabolic disease. This area you see here is where I took a biopsy. This was a cat that I take with me everywhere because this was one of the cats who taught me many, many things. And part of my early years was I biopsied everything because I had this need to know. Now I rarely biopsy anything because I know. Okay, here's another atopic cat. And again, cats have great imagination, as we've talked about. And so typically you'll see this reaction pattern on the ventral abdomen, medial thighs, medial forelimbs. The next cat may decide to do a racing stripe right down the middle of the back. The next cat may decide to do, a racing stripe down the middle of the back, as well as a couple peripheral stripes. So give the cat a lot of leeway in its creative tendencies. They can really be quite the conversation piece and the type of hair loss that they produce. Atopic disease, we understand, is genetically programmed in many ways, although a lot of that work has yet to be done in the cat. And these are two littermates who were living in the same household, and they were both 1.5 years of age and on exactly the same day, according to the owners. This cat started excessively grooming the ventrum medial thighs, and this cat started doing racing stripes down the dorsum. Different presentation, but again, all within the realm of the intelligence of Felis domesticus. Here's a cat that was sent in for allergy testing, and the cat had been visibly over grooming over the back. And as you looked at the skin underlying these traumatically hypotrichotic and alopecia areas, as you looked at the underlying skin, it appeared perfectly healthy. This cat had gone through a reasonable novel protein diet with no response. The cat had received quite adequate doses of glucocorticoid and had a poor response, meaning the pruritus did not, the over-grooming did not totally subside. And usually atopic cats, at least early on, respond very well to appropriate doses of glucocorticoids. So this threw up a big red caution flag. Maybe we ought to think of something else before we get into allergy testing in this kitty. Or the referring veterinarian's diagnosis was psychogenic hair pulling. That was a very big diagnosis back in the 70s when we didn't know any better. More about that in a little bit. But we decided to do some combings on this kitty, and we didn't find any Chilatiella mites, but we did find several typical Chilatiella eggs attached to this cat's broken off hair shafts. So, oops, I keep doing that, don't I? All right. So maybe this is not the cat's entire reason to be pruritic, but it's at least one that we can cure and see how pruritic the cat is after this is taken care of. So this cat was treated with appropriate acaricidal therapy, and the pruritus, fortunately for us and the cat, totally disappeared. Cautionary word about chilatiolosis in cats. If you do skin scrapings, in general, you find mites on about 10% of the cats who have chilatiolosis. If you do tapings with Scotch tape over many areas of the body, you up that percentage to about 20%. If you do combings with a flea comb or a louse comb and harvest large areas of exfoliative material and put that into mineral oil and look at it under the dissecting scope, you can get a positive idea of Chilatiella mites and or ova in about 45%. So what I'm telling you is Chilatiella in the cat is kind of like sarcoptic mange in the dog. If you have any reason to suspect it, you better take a time out and treat it. Because again, you do not want to miss a curable disease, and you're only going to document the presence of mites in less than 50% of the cats who are infested. This is a kitty who was presented for fur mowing that you can see over the ventral abdomen and medial thighs, and hairs broken off at various lengths. And again, this cat was referred into the behavior service for psychogenic overgrooming. And they had us consult on the case before it went on its heavy-duty anti-anxiety, mind bending, if I can use an early 60s experience from California, mind bending drugs. And when we did surface sampling on this kitty, we found several otodectic mites. Now here's the deal. We all know that ectopic otodectes infestations have been described and occur in cats. What's interesting to me is, in my experience, the cats where we've demonstrated ectopic otodectes, when we go back and examine their ears are often absolutely normal, and we are unable to visualize or harvest any mites from the ear canal itself. And so watch out for that. But now we have a cat who has otodectes running over its skin. Is that the cause of all this hair pulling, or is it just a distraction? Well, we have no way of knowing that looking at the cat. And so again, we have to take time out. We have to treat this ectoparasite and see if all the clinical signs in our patient disappear. And fortunately for us and for this cat, surface treatment with the caricides resulted in a total cure. A more recent thought process in the fur mowing cat is infestation with Demodex gattois. And this is a cat who was referred in for hair pulling in typical place all over the ventral thorax, ventral abdomen, medial thighs. Skin was basically normal. These two excoriated areas you see are from me doing skin scrapes. You know, sometimes things have to get worse before they get better. I try to get owners on my side if I can. So the skin often looks quite normal, maybe some flaking, maybe some mild erythema, depending on how long it's been going on. But it's usually in the differential of this symmetrical fur mowing animal. This is a surface sampling from this cat showing us this short, 100 micron or so in length, typically Demodex mite. A word of caution in Demodex gattois infestations. Oftentimes you cannot find the mite by surface sampling. And if you do surface sampling, I would encourage you to take your samples from haired areas where the cat is not able to lick. That's the most likely place to find the mite. In many of the cats, we make the diagnosis by doing concurrent fecal flotations, because if you think of it, the cat is removing this surface mite all day long as it overgrooms. And there's, in our experience, you're more likely to find the mite in fecal flotation than you are with various forms of surface sampling, be they scrapings, be they tapings, or be they combings and concentrating material. So here's our differential for this particular presentation. Again, the typical allergies are at the top in prevalence data, but we want to make sure that certain parasites aren't there tickling the skin, not producing clinical inflammation, but causing the cat to produce its own hair loss. One of the endocrine diseases that will mimic this presentation is hyperthyroidism. But of course, as clinicians, we understand that there are other problems going on in this cat other than just fur mowing. The cat's probably eating more than normal. The cat's probably losing weight in spite of that. The cat may be quite anxious. You may be able to palpate enlarged thyroid, all of these types of findings. Lastly, a quick word, although if you read veterinary dermatology literature in the late 60s and 70s, you would have thought that psychogenic or behavioral overgrooming was quite common in cats. And that's because, in part, we did not see gross evidence of inflammation. We were expecting to see that based on our experience with the dog. But then we finally understood that cats are not dogs. They're much smarter than dogs, and they like to do things that confuse us and put us off on the wrong track. And so what we can say today is the cat who presents for over-grooming, as we've demonstrated here, the chance of it truly being behavioral are extraordinarily rare. If I go back to that study that Bill and I published a few years ago, over 1,400 cats, 0.3%, that's 0.3, actually were documented to be behavioral by the classical environmental stressors that you might find that would trigger this kind of behavior. So if you remember nothing else, remember this: most cats are totally sane. They just itch. The third reaction pattern that we might see in the allergic cat, and therefore triggered by other diseases we need to first recognize and treat out at present, is the eosinophilic granuloma complex. This is an atopic kitty whose major manifestation of its allergy are these large, raised, generally flat-top, erythematous, exudating alopecia plaques. This is probably just about the most pruritic condition that a cat can have. Typically, they're on the ventrum somewhere, medial thighs as well, although in any given intelligent cat, it could be anywhere that the cat wanted it to be. This is a close-up of those same exudative lesions. This type of lesion, if you gently block the surface so you get rid of some of the secondary changes of bacterial colonization and neutrophils and such, and then gently squeeze this lesion and create a few drops of material from within the lesion, touch a slide to it, it's usually just about 90% eosinophils. This is a cat who has eosinophilic granuloma, and those occur in two places in general: up around the face somewhere, to include the lips, and of course on the caudal thighs. Whoops. Clearly I'm heavy-handed here. You wouldn't think I'm a guitar player and play in a rock and roll band, but you know, stranger things have happened. So here's these lesions. They're very palpable. They thicken and distort the skin wherever they are, and tend to develop these surface areas of whitish to yellowish discoloration. Here's another cat who is allergic to food. We only could go as far as saying it reacted to the commercial diet it was on. The owners would not let us do specific food challenges. And this cat has the indolent ulcer form, where literally it's an ulcer. There is no palpable lesion here. That's a big distinction to make. This little drop of blood you see up here is where a needle was inserted to try to get some exfoliative cytology. If you do get representative exfoliative cytology from this type of lesion, typically it's pure neutrophils. Rarely is an eosinophil seen. Here's the other classic form of the eosinophilic granuloma, if not around the face, then on the caudal thighs, often symmetrically, more or less, although it can be severe on one side than the other. And again, you have this linear configuration of these elevated solid nodules and plaques with this sort of, to my eye, yellowish, pinkish surface appearance, very, very typical of the eosinophilic granuloma in the skin. And here's a cat with just wall-to-wall eosinophilic plaques all over the abdomen and ventral chest, associated with a reaction to its commercial diet. This is what I'd call eosinophilic plaques like your mama used to make. No one makes them better than mama, and no one makes them better than cats. One of the oddball causes of eosinophilic granulomas, in my experience, would be those cats who develop an eosinophilic granuloma response to their preventive spot-on parasiticides. And this is a kitty we worked with over the course of several months. And the owner decided she was tired of putting a spot over the back like everyone told her to, because the cat always developed this plaque-like lesion. So she decided to change the site she put it on. Well, unfortunately, the plaque-like lesion went there as well. What was interesting with this particular cat is this happened initially with a spot-on containing selamectin. We decided, okay, maybe it's due to the selamectin. Let's switch to fipronil. And we tried the fipronil spot on, same reaction. We said, well, let's try yet another one. And we tried moxidectin imidacloprid. Same thing happened. So I doubt that this reaction had anything to do with the active parasite, active ingredient. I think it's all about the what's in the vehicle for these. And of course, that tends to be proprietary information, but I'm assuming the vehicle had similar ingredients throughout the three products to consistently produce this eosinophilic plaque reaction. These next two slides were given to me by a great friend of mine, Kenny Mason from Australia, who we owe the whole concept of mosquito bite allergy to. And Kenny gave me these two slides. And again, when I lecture on this topic, I always lecture about Kenny as well, because he's a great guy. These type of cats have typically developed eosinophilic plaques and granulomas in thinly haired or hairless areas that mosquitoes have easy access to. So typically beginning on the nasal planum where there is no hair, around the margins of the pinna where it's often thinly haired, you can actually see these on the eyelids. And for those cats who like to lay down with their paw pads facing up, you can actually see lesions on the paw pads as well. This is one of Kenny's pictures, probably my favorite picture of all times in veterinary dermatology, because we not only see the disease, but we see the perp right here. Here's the perpetrator and the disease. Images don't get much better than that. Thank you, Kenny Mason, for everything you've done for veterinary dermatology. For the eosinophilic granuloma complex, then, here's our drop-down list. It's a little bit longer, a little bit different than we saw for the first two reaction patterns. We talked about the contact dermatitis seen with spot-ons, for example. You will see cats who develop eosinophilic granulomas, especially around the face, the temporal area, on the tongue, where their owners have ornamental plants inside the house, often cacti or something with tines on it. The cats, for some reason, like to nose those or lick those or rub up against them, and they will present with eosinophilic granuloma type lesions that are very resistant to glucocorticoid therapy because, of course, there's a foreign body in there. And until you find out, either by biopsy demonstrating the foreign material or surgical excision, those are very difficult to cure. But once you figure it out, simply removing the cat from the tine-containing plant cures the problem. So that's very important information. We will see cats, sorry about this, folks, but I just seem to be electric. I'm dragging slides all over the place here. And I apologize for that. But, you know, on the other hand, for me, it's a diversion, and I'm kind of digging it, so I hope it's not too distracting for you. Staphylococcal infection. There are many cats who appear to have a very unique relationship with staphylococci, coagulase positive staph. Probably most of the time now Staphylococcus pseudointermedius, where they will present with a typical eosinophilic granuloma. It could be on the lip, it could be on the face somewhere, could be anywhere. wherein it looks typical to you. You give your favorite treatment, which oftentimes early on is some type of a glucocorticoid, which you would expect most cases to totally resolve with, at least while they were under the influence of the glucocorticoid. But this particular case, there's only a partial improvement. The inflammation and the swelling reduced by maybe 50% or so, but the lesion continues to be there. If you do exfoliative cytology on these, what you find is instead of the expected eosinophils and macrophages, aka eosinophilic granuloma, you find numerous neutrophils with extra and intracellular cocci. So this poses two immediate questions. Is this an eosinophilic granuloma with secondary bacterial infection? Is that why I'm having an incomplete response with my glucocorticoid therapy? Or could this be one of those cats who appears to have this unique relationship with staphylococci, and it's all about a staphylococcal infection and a hypersensitivity response there too? The only way I know to answer that question presently is to treat this cat only with antibiotics, because if this is an eosinophilic granuloma triggered by a unique reaction to an infection, then the entire lesion disappears. If it's secondary infection on top of an eosinophilic granuloma, then again, part of the lesion will reduce, discharge will disappear if there's any, but there will still be a lesion there that now is the eosinophilic granuloma that probably will respond to your typical glucocorticoid intervention. So if you're having problems with them, think about foreign bodies and what they're exposed to in their house. Think about an odd reaction involving staphylococci, and certainly always ask the question over and over and over again, what drugs are you taking that I might be able to stop or at least change to a drug that accomplishes the same thing that doesn't have the same chemical structure. The fourth and last reaction pattern that we see in the allergic cat, and then produced potentially by many non-allergic things, is so-called papulocrisis or miliary dermatitis. This is an image given to me by George Muller. Oh my goodness. One of course, the legends of veterinary dermatology. And again, I take George with me everywhere I go because I personally owe so much to him, as you do, as we all do. So this was one of his great photos of a cat who has the miliary dermatitis reaction pattern. And you can see these small crusted papules. Typically in the beginning, the owners can feel these as they're petting their cat long before they can actually see visible skin disease, which will get worse as time goes on, of course. And so these are typically distributed all over the dorsum, around the neck, although they could be all over the cat's body, depending the diagnosis and depending the cat. This happened to be due to a flea bite allergy. That would be less common in our area than this be doing due to atopic dermatitis. Of course, there's many ways to try to get a handle on whether fleas are a player in this. We can look for the presence of flea dirt, but remember the cat's removing that on a minute-by-minute basis, and the owner might be removing it with various topicals as well. Owners can certainly develop their own flea allergy. This is a young lady in a household with a cat who has flea allergy and fleas, and she's getting her own miliary dermatitis in a very typical area, distal extremities. This is also a picture given to me by George Muller, and it's actually a flea that he positioned on his own arm and allowed it to bite so that he could take a picture for all of us to pass on for eternity. George spared no limits and no expenses to demonstrate various aspects of veterinary dermatology. Thank you, George, you're amazing. Remember though that seeing fleas or seeing flea dirt does not equal flea bite allergy. So what it suggests to us is fleas are a component here. Are they the entire problem? Or does this animal have flea infestation on top of atopic dermatitis or on top of food allergy? And again, the only way to know that and clear the way for your allergy workup and therapy is to take time out and let's treat this animal appropriately and all of its housemates and its environment if necessary for flea infestation, and regroup 8 to 12 weeks later and say, is this animal all cured now by simply addressing the fleas, or is there still dermatitis to be dealt with and we can move on to, for instance, allergy? This particular cat I was showing you with miliary dermatitis here certainly could be flea allergy, could be atopic. In our routine workup, we were able to demonstrate Chilatiella mites with their classic hook mouth parts and ova as well. But remember, that's actually a fortunate finding because over half the time you're not going to find it. So if you suspected it, if the animal has access to animals or environments where it could pick up Chilatiella, then we have to take time out, we have to treat and reevaluate in 4 to 6 weeks. Chilatiella egg. Chilatiella is another possible zoonotic ectoparasite. It does like to bite people, and these are little pruritic erythematous papules on the arm of a owner of a kitty with Chilatiella. We find that if you look at retrospectively at all the households wherein we've diagnosed at least one pet with Chilatiella in the household, that there's at least one owner, maybe more, but at least one owner who shows typical Chilatiella bites in about 30% of those households. So that can be a useful supportive piece of information for at least a zoonotic ectoparasite. In our part of the world, the Northern Hemisphere, we certainly do see pediculosis, although less and less as we mentioned, our topical parasiticidal and aericidal products become more and more used. Typically, it's a winter and early spring type phenomenon in closely housed animals. But again, lice is typically a macroscopic diagnosis. You see them, you see the nits, but if you want to show veterinary students or you want to show somebody on a webinar what a louse looks like and its nits look like, you can do that. So when we see this cat with miliary dermatitis, we understand that there's a fairly lengthy differential diagnosis. And so the first thing I would encourage you to do is some cytology. Find one of those tiny crusted papules, gently squeeze. You don't want to squeeze so hard that you get blood because you'll just see blood, but squeeze just the clear drop, hopefully of serosanguinous material, and put it in diff quick and see what you have. This is from a cat with flea bite allergy, but the thing I would like to say about this is if you're sampling miliary dermatitis due to allergic or ectoparasitic causes, the cytology is identical. You find lots of eosinophils, and oftentimes you find lesser number of basophils as well. Now, for instance, I've never seen a basophil on cytology of an allergic or ectoparasitic dog in my life. Again, they're just too stupid to be able to do that. But what this tells me is I have an allergic cat or an ectoparasitic cat. It doesn't tell me which. On the other hand, if I did the same exfoliative cytology and found this image where I had a lot of degenerate neutrophils and a lot of phagocytosed cocci, well then, at the very least, I have a bacterial infection, probably Staphylococcus pseudointermedius, but at least I have an infection. The question is, do I have this bacterial infection superimposed on something else, or could this be one of the cats who just has a bacterial infection? Well, there's only one way that I know of to figure that out, and you put that animal on an appropriate antibiotic, and you reevaluate 2 or 3 weeks later. If it was all bacterial infection, well, then you ought to have just about a totally cured cat. That would be the least likely thing in my experience. If it was secondary infection, then at least the cat ought to be clinically much better. Fewer lesions, less exudative crusted lesions. And maybe this time when you did your exfoliative cytology, you'd find the eosinophils and or basophils that are more typical of the allergic or ectoparasitic cat. One of the uncommon differentials for the miliary dermatitis pattern is dermatophytosis. Typically, if you do exfoliative cytology from that cat, you see a lot of neutrophils, degenerate neutrophils, but you do not find the cocci things to make sure, A, that we should pursue allergy, and if the cat does have an allergy but has staphylococcal infection, we're going to find that the allergy is much more difficult to treat until we recognize and get rid of the staphylococcal infection. If it has Clilatiella, the allergy is going to be much more difficult to treat successfully until we get rid of the Clilatiella. So the diagnostic approach, if we summarize things from the examples we've looked at with associated reaction patterns, then like we always say in veterinary dermatology, history and physical are everything. It's often said that if you do a good history and you do a good physical exam, you've got 90% of the information that you need. And I'm certainly a proponent of that. So is this seasonal? Well, you might not know that if you're the primary care vet and it's just appearing for the very first time. But as we watch this animal over the period of a year, does this have some seasonality, suggesting maybe exposure to parasites, exposure to allergens? Is this locational, meaning is the animal very, very bad outside, but much better indoors, or vice versa? Of course, that could be telling us something. For instance, many atopic cats in our practice in the northern United States will be very seasonal, but only seasonal in cold weather. And that's because in warm weather, they're outdoors away from the house dust and human dander and everything that's concentrating. In winter, when everybody's inside, the windows are all shut, forced air heating is on, and the allergens are going berserk. So locational expression of disease can be quite informative. Do I have exposure to some of these things? I might not go outside, but does my family, friend, cat, and or dog go outside, come and go, and potentially is bringing me things that I react to more than my asymptomatic but carrying housemates? Is there evidence of contagion to other animals, cats or dogs? Is there evidence of zoonosis, as we talked about? Can you find ectoparasites? Less easy to do in the cat than the dog. If it's an older cat, does it have a thyroid slip? Surface sampling. I'm a big fan of combing. I often don't do many scrapes and tapes anymore, especially if I'm looking for surface parasites. I just find that the concentration of materials in combing is much more efficient for me. Should I be doing a fecal exam? We diagnose intestinal parasite hypersensitivity very rarely. But if this animal was not on a preventive, I would certainly be doing a fecal. And you know, there's nothing more that I like at my age than having history come back and recycle. It gives me this warm, fuzzy feeling. Cytology, is there bacteria that could be the whole problem or more likely secondary? And we need to recognize it and treat it before we can successfully manage our allergic cat. Should we be doing plucks and culture for dermatophyte? And again, some of the information on exposure and zoonosis and contagion could help us. If this animal's on a drug and there's any way to stop that drug and not put the animal's health at risk, should we be doing that and reevaluating in 3 or 4 weeks? We suspected a parasite, but we can't find it. That's very common in the cat. Should we take time out and do a response to a parasiticide? We have so many wonderful, safe ones, owner-friendly ones to use these days. How about glucocorticoid responsiveness? And remember, in the cat, you need higher doses of glucocorticoids to accomplish what you might do in a dog. So personally, I wouldn't use anything less than 2 mg per kg of a prednisolone or equivalent for 24 hours, every 24 hours. And if it's glucocorticoid responsive disease, that ought to be very obvious within 24 hours to maybe 3 days. If it's not glucocorticoid responsive, then that makes me go back and reevaluate the possibility of secondary infections, of parasites, or it could help me prioritize food allergy. Novel protein diet, that's a 2-hour lecture all by itself, but we don't get to that until we've done all the other footwork to make sure that we're not wasting the owner's time and we're not putting ourselves in a position where it's impossible to evaluate the response to a novel protein diet. How can we do that if there's bacterial infection on board? How can we do that if there's Klebsiella on board? We can't. And then ultimately, when we've gone through all of those steps and evaluated effectively a novel protein diet, now we're allowed to make the diagnosis of atopic dermatitis, right? There is no test that diagnoses atopic dermatitis. It's ruling out everything else that looks like it. And at that point in time, we might start talking to the owner about various things we can do to look for reactivity to antigens. Well, I don't know about you, but I've had a really good time for the last however long I talked, but it's easy to have a good time when you're talking about stuff you enjoy and you're talking to people who hopefully enjoy that same material and are going to take that material and go forward and make a difference in this profession. Because people like me, I know what, we're done, we're history. But you folks are the future of veterinary medicine and veterinary dermatology, and I am counting on you. Do not let me down. Thanks so much. Have a good one.